Washington State University. Go Cougs!
So some of the challenges we've identified in the last decade with working with older adults is they lack the experience. There are some people that are excited because when we first started this research a decade ago, we were the ones giving them smartphones. Like I said earlier today, almost 97% of Americans already have smartphones. But a decade ago, that wasn't true. So they were really excited when we gave them a smartphone and we were teaching them how to turn it on and things like that. So we kind of have overcome that lack of experience just because of evolution of modernization. Low self-efficacy is very common. What we need to have for older adults is something that's user-friendly and they love a lot of photographs. So having links with words on it, like I showed you on my blood where it said my medication regimen or things like that, they just want to see a picture of a pill or something. And that kind of is what's user-friendly for them. They have issues with touchscreens. They get very annoyed. They're like, oh, what I was reading just disappeared because I moved something, and then they can't go back to the other screen. So we also try to deal with that by not providing them actually with the option of you can use your own cell phone, or we can download the apps on your cell phone, or we can provide you with a new one. And that, of course, comes with its own challenges because then they're now using more megabytes on their cell phone. So from the research standpoint, it's difficult for us to also determine how much of their phone charges we have to cover. We have to remember older adults have impaired vision and hearing, so we have to have larger buttons, longer reaction time, extra loud speakers, hearing aid compatibility. All of this kind of has to be weighed in with the size of the phone, because when you give them a bigger device, they're like, oh, that's too big, I can't carry it around. So you want to try to go smaller with like the iPhone, the latest iPhone models, but then you kind of lose the options of what I just described as larger buttons, longer reaction times, and like things like that. And then in our very first few studies in the early 2000s, what we noticed was there was always issues with charging. When I worked with the Wireless Health Institute at UCLA, they used to carry around an accelerometer, and the accelerometer would record physical activity levels that were so low, and then we'd see that the battery just died, and actually, so it's not, again, reporting an accurate figure. Now, what they've come up with recently, a term that now is being used in the research world, is co-designing. How many of you have heard before of community participatory action-based research before? Great. Most of our clinicians. This is almost the same concept. Community-based participatory action research used to be where when we developed some kind of intervention, we would have members of the community, stakeholders, like let's say a restaurant owner or people that have investments in caring for that patient population would participate in the design of the intervention. But the co-design approach emphasizes more. The difference with the co-designing approach is it emphasizes more the participation of the patients. And this is the model and paradigm that we're now trying to embrace, where every intervention that we're developing involves the patient in the process. So what we do originally first is we start with a needs or content assessment, and that we do by having focus groups with patients that are suffering from a certain condition. Then I come to my colleagues in computer science and bioengineering, and they develop a prototype or some kind of solution. And right now, like I said, we have an R21 that's being funded where we're kind of in between the innovation and the development and modification. So it's a 2-year grant. We've kind of spent the first year really focusing more on building the prototype and pre-testing it more in the lab setting, which is here in WSU. And then now we're at that phase where we're testing it with real patients, and the real patients are telling us, we don't like this, or this is not good enough, or this could be helpful for us. And so I'm kind of like the person that communicates between the patient and the developers. And that's kind of the co-design process. So we're hoping that this refinement and this reiterative process will help us come up with the best intervention possible. So you need to have, like I said, community advisory boards. We kind of try to involve, and right now in our studies, a lot of the community programs, public health, Center for Prevention Research in the Los Angeles setting. So this is the very first, like I said, a decade ago, we designed what we call the Wanda Analytics Engine. I was just an assistant professor then, brand new. Hassan, I think, was a postdoc. When we developed all of this. And we literally started with so many options. We were testing, we were the patients, actually. We were testing all the devices on ourselves and making sure it worked. We wanted to make sure that the weighing scales would transmit the data over to a centralized data bank. And so we did all of the data collection and optimization. And then we ended up recording symptoms for them. On a daily basis, not only did they have to weigh themselves and take their blood pressure, but they had to answer all of these questions every day with a yes, no. Now, did they like that? They were like too time intensive. So we immediately had to take out this daily symptom reporting and try to spread it over the week so we could at least still capture the same symptoms, but not on a daily basis. We tested this device first in 21 patients and then compared them, and you'll see this is the demographic characteristics with a sample that was age and gender matched for them that didn't have access to this Wanda device. And what we saw was that patients that were using the innovation were very positive about not having any problems with taking their daily weights, their vital signs, and transmitting data. Like I said, what they hated most about it was completing that symptom report, way at the bottom, 66.7%. When we asked them about their perceptions of acceptability, they said it was pretty simple to use. It helped them feel in control. They learned to use it quickly. But what they said was giving them instructions when we went to set up the device was not sufficient. So what we've learned from this practice is what really works now for patients is that when we give them a take-home manual, just like how to build your bicycle or things like that. So when we give them a manual now that has all of the instructions for the different options, that's what they love. So when I actually work with Dr. Crandall's engineering students in the last 2 semesters last year, one of the things I really emphasized to them was, can you make sure at the end of building a program for dying patients with heart failure that we can have a manual that we can give to them on how to best access the resources that would help them at the phase where they're at end of life. So that is what we learned from this. Would they recommend it to a friend? They were very positive. So we did this mini study. We also saw that there were improvements in how they perceived their health was from baseline to 3 months. We called the program either Wanda or Smarter Heart. And you'll see that perceived health, quality of life, which is the health-related quality of life, anxiety and depression were better over time in the group that had the device. But it's a very, very small sample, and we should have still gone to the phase where it was more reiterative and we went back to the patients to say, how can we improve it? But what happened at that point was the AHRQ had a special call for big grants, and all of a sudden, one of our colleagues from the School of Medicine at UCLA just said, well, let's go for it. So it's a once in a lifetime opportunity. And here I am with the Wireless Health Institute collaborators that I was working with. And all we did was we simply gave them our proposal on what we developed and this small, very small study. And we ended up getting a $9.9 million grant. Was it successful? What's your guess? It was not successful. And basically, the whole point of what I'm trying to bring to you guys is we can't just do these small studies and say, let's go full-blown to a randomized controlled trial. We did the study, actually, these are the results of the big study. It involved all the UC medical centers, which included UCLA, UC Davis, UC San Francisco, and UC Irvine, plus Cedars-Sinai Hospital, which is one of the biggest metropolitan hospitals in Los Angeles. We enrolled a total of 1,437 patients, and basically, without you reading this abstract, our findings were there were no differences between the groups. And now they're making me, as the only nurse investigator on the study, look back and say, well, what did we do wrong with the proposal we borrowed from you? And I'm like, you get a $9.9 million grant. I don't get any acknowledgement for having written everything. And now that things went wrong, you're like, what's wrong with what you proposed? So now we're looking at the data, and literally, I think what we did wrong with this major grant is that we didn't set up the innovation using the co-design process in the way that we should have. And we should have taken slower steps towards achieving what we wanted to. So it's something we need to publish, I think. This study is just literally saying there were no differences. And the take-home message in this particular case, when you have such a big randomized controlled trial like this, is that, well, let's just end it, right? But my message is, let's do things right. Let's do things the right way. And that's what we're trying to do now, more slowly, taking it at a pace that we're actually listening to what the patients need. My assumptions or speculations at this point is that at some point the patients just stopped using it and they weren't transmitting the data. So there was an issue with adhering to using the devices that we were not able to truly capture, and that's why there were no differences. We didn't know, probably if we analyzed the data based on who adhered and who didn't, then perhaps then we probably would have seen the differences we wanted. So that kind of wraps up my presentation. I think what we learned from that very big project and all that money was that we need a lot more work before we tread again into a larger randomized controlled trial. We need to look at safety impacts associated with designing ICT solutions. We need to look at, like I said, acceptability and psychosocial impact, cost and cost effectiveness. We have this way when we're submitting grants where we're like, we always say it's highly scalable, and what we learn from our center can be generalized to all centers in the United States. And right now, it's all fluff. And pretty much reviewers are recognizing that it's no longer true. We have to have data to show how scalable these interventions are going to be. We need to include relevant bioparameters, weight, blood pressure, heart rate. Now we're starting to get into wanting to know what their daily cholesterol levels are. And for patients, heart failure patients that are also diabetic, we also want to know their fasting blood glucose levels. So these are things we're now starting to integrate. We want to look at what's acceptable to clinicians and supporting organizations. Like I said, going back to our big study, we literally just implemented what was still prematurely not ready, and none of the clinicians who were on the study also thought it was a good device. So a lot of resistance, not only from the patients, but from the healthcare providers. We want to look at technical performance of ICT solutions, and then equity of ICT solutions for self-care interventions for the different demographic groups. One of the biggest challenges, I think, also with writing grants that have ICT component is the privacy policies of our community. I mean, we can say that we want a social media availability for these different apps that we have, but then when you bring that into a grant, they'll say, well, social media means everyone's going to see what the patients are putting, and it's no longer the identified data. So these are some of our challenges.